We discussed about superior capsular reconstruction, tendon transfers, RSA, but not about rotator cuff repair. So let's have a look what is the result if you just repair the cuff. First of all, let's start with the definition. Pseudoparalysis has been described as the inability to actively elevate the arm above 90 degrees with free passive range of motion and no, of course, neurological deficits in the setting of a massive rotator cuff tear. So based on this definition, this patient has shoulder pseudoparalysis. However, according to some new publications, there is a trend to differentiate between pseudoparalysis and pseudoparesis. And based on these new definitions, pseudoparalysis is the condition that there is active scapular plane abduction less than 45 degrees, and pseudoparesis when there is active scapular plane abduction between 45 and 90 degrees. So based on this definition, this patient has a pseudoparalysis, and the previous one has a pseudoparesis. Of course, in all these situations, there is a strong correlation between the size, of course, of the tear, the location of the tear, and of underlying importance is, of course, the integrity of the subscapularis tendon. We're all aware of this landmark paper of Philippe Collin, who described the relationship between the massive rotator cuff tear and loss of active range of motion. He divided these patients into 5 types, and as you can see, you can have pseudoparalysis when you have rotator cuff tear in supraspinatus, infraspinatus, the upper part of the subscap, the whole subscap. But once again, it's not a requirement that a patient with pseudoparalysis have a ruptured subscapularis tendon. Unfortunately, this is a big part of our patients. Almost 40% of all rotator cuff tears are classified as massive tears. And another problem, I would say, is that what a rotator cuff tear is repairable or not, it's something really very, very controversial. And at least to my perspective, you don't know until you get in the shoulder, mobilize the tendons, and then you can decide if this tear is irreparable or not. Of course, before going into the joint, before the operation, you have some negative risk factors like the anterior superior subluxation, the advanced fatty infiltration, and an acromion humeral distance less than 5 or 6 millimeters, which is, to my perspective, probably the most negative factor to go for a rotator cuff repair. So let's see what the literature says about the effect of the repair. This paper from Berhard back in 2007 reports that there was a clinical improvement in almost 87% of the cases, independently of the Goutallier criteria. And when we discuss about rotator cuff repair in massive rotator cuff tears, of course, the treatment should be individualized. We heard before in the battle that this guy, 68 years old, which is, should be, let's say, borderline for RSA, but I think in this case, 75, 74 years old, with advanced fatty infiltration, nobody would do anything else except reverse shoulder arthroplasty. However, when we're dealing with younger patients, then there is an option for rotator cuff repair, and you have to follow all these rules. This is an example of a 48-year-old lady with a pseudoparesis, not a pseudoparalysis, based on the new definition, and she has no advanced fatty infiltration, so we tried to do a rotator cuff repair. In all these cases, we check after the releases if the tendon comes to the footprint without any difficulty, with not so much tension. And if this is the case, then we don't use the biceps to incorporate it in the repair and do it as superior capsular reconstruction. Otherwise, we use the biceps as an augmentation and to use it for superior capsular reconstruction, but this is not the case for what I'm talking right now. So what is important also is that you have to use at least 3 triple-loaded anchors in order to have multiple points of fixation. And of course, the release is very important. Gradually, I will not run the whole video for the sake of time, but gradually you will see that you have a nice reduction at the end of the operation in most of these cases. Maybe not all for these cases, but in most of these cases. So as for the rehabilitation, you have to go slow, of course. You have to give time to the tendons to heal, to the tubercle. That's why for 6 weeks we use an abduction brace, and no active motion is allowed before 3 months. So this is our material in the last years, 46 patients. Most of them were male, young patients, mean age close to 60 years. Subscapularis involvement was the case in the majority of cases. Pseudoparalysis in 68%, pseudoparalysis in 32%. And these are some examples of the patients. This is the patient that we saw before in the video. This is the result after the repair. The patient we saw, the lady with pseudoparalysis, and this is the result after the repair. So in general, the reversal of pseudoparalysis was possible in almost all cases, 97%, reversal of pseudoparalysis in 80%. Of course, constant score and UCLA improved significantly, and we're waiting for the MRI results. This is an ongoing study, and I'm really looking forward for the MRI results. So based on the literature, as you can see, other authors report similarly good results. In this paper, they divide the patients in a primary repair group and a revision group. As you can see, in primary group, 90% of patients had a reversal of pseudoparalysis. Once again, this is an old paper, and there is no separation between pseudoparalysis and pseudoparalysis. In revision cases, only 43% of patients gained full forward flexion more than 90 degrees. This is another study from Korea with 29 patients. As you can see, again, reversal of pseudoparalysis in 75% of cases, although the calf healing was achieved in only 1/3 of patients. And this make us thinking of what we discussed this morning, if a healed calf goes with the function of the shoulder. Another paper, again, very good results. Pseudoparalysis was observed in 95% of the cases, and this is from American Journal of Sports Medicine in 2015. So this is another paper which reports the cost-effectiveness of various procedures, and as you can see, the result and the conclusion of the authors was that the primary arthroscopic rotator cuff repair in patients with massive rotator cuff tears is really a cost-effective procedure and before reverse shoulder arthroplasty. So in conclusion, I would say, based on the literature, based on my personal experience, that the arthroscopic cuff repair is a reliable option and can lead to a reversal of preoperative pseudoparesis or pseudoparalysis. The functional result is probably more predictable in case of pseudoparesis. There is a question, of course, based on surgeon preferences, if this should be the first-line treatment. But the choice to perform an arthroscopic rotator cuff repair or not, I think is based on surgeon preference, except the objective criteria that we have before surgery, MRI, ultrasound, etc. And most probably we need more studies to analyze all these factors and what is the best way to go with patients with massive rotator cuff tear and pseudoparalysis. So once again, thank you very much, and looking forward to welcome in Milan for the ESCA Congress. Thank you very much.